Every morning you wake up, you walk to the bathroom or the kitchen, you open the cabinet, you take your blood pressure medication. You have done this for years, maybe decades, and your doctor has never once asked you what time you take it. That silence may be costing you more than you know. Here is what most people taking blood pressure medication have never been told. The human heart does not work on a flat, even schedule throughout the day. Blood pressure follows a specific 24-hour pattern. It drops while you sleep. Then, in the 2 to 3 hours before you wake up, before your alarm goes off, before your feet hit the floor, your blood pressure begins to rise, sharply, deliberately, as part of a biological preparation for waking. By the time you open your eyes in the morning, your blood pressure is already climbing, and it continues climbing for the next 2 to 3 hours. This is called the morning blood pressure surge, and here is the number that should stop you cold. The majority of heart attacks occur between 6 in the morning and noon. The majority of strokes occur in the same window, not randomly distributed across the day, concentrated, in the hours when blood pressure is at its highest point. Now here is the critical question that your doctor almost certainly has never discussed with you. If you take your blood pressure medication in the morning, after you wake up, after the surge has already begun, your medication is reaching its peak effect in the afternoon when your blood pressure is naturally falling anyway. And it is wearing off in the early morning hours, precisely when your blood pressure is surging and your cardiovascular risk is at its highest. You are taking your medication at the wrong time, and the research on this is not ambiguous. My name is Dr. William Harris. I am a geriatric specialist, and today I'm going to walk you through exactly what the science shows about blood pressure medication timing, the study that changed how cardiologists think about this, the specific medications that should move to bedtime, the ones that must stay in the morning, and the exact conversation you need to have with your physician. Stay with me through everything, because the last section, the specific words to say to your doctor, is the most important thing I will tell you today. Drop a comment right now. Tell me your name and where you are watching from. And tell me, what time do you currently take your blood pressure medication? Morning, evening, or do you not even know? I read every single comment. Let us go. And I want to give you a warning before we get into the science. There is one medication category that must absolutely stay in the morning, and if you switch it to bedtime without knowing this exception, you could end up making multiple trips to the bathroom every night, fragmenting your sleep and increasing your fall risk significantly. I will tell you exactly which one it is. But first, you need to understand why this matters at all. To understand why timing matters, you need to understand what your blood pressure is actually doing while you sleep. Your body runs on a 24-hour internal clock. During sleep, blood pressure drops, typically 10 to 20% below daytime levels. Then, roughly 2 hours before you wake, cortisol begins rising. The sympathetic nervous system activates, and blood pressure starts climbing before you are even conscious. By the time you open your eyes, the surge is already underway. In adults over 60, blood pressure can rise by 25, 30, sometimes 40 millimeters of mercury from its overnight low in the first hour after waking. In people with hypertension, this surge is often even more pronounced. Here is what that surge does to your cardiovascular system. The sudden rise in blood pressure creates mechanical stress on the arterial walls. If there is atherosclerotic plaque, the fatty buildup that lines the arteries of most adults over 60 to some degree, that mechanical stress can destabilize it. Plaque that was stable can rupture. When plaque ruptures in a coronary artery, the result is a heart attack. When plaque ruptures or a clot forms in a cerebral artery, the result is a stroke. And here is what makes this particularly dangerous for adults over 60. As arteries age, they become stiffer, less elastic, less capable of absorbing and buffering the mechanical impact of a sudden pressure surge. A 35-year-old arterial wall has flexibility that absorbs much of that force. An arterial wall at 68 or 72 is more rigid, more like a pressurized pipe than a flexible tube. The same surge hits harder. The same plaque instability risk is amplified. This is why the morning hours are not equally dangerous across all age groups. For adults over 60 with hypertension, the morning surge is not just a statistic. It is the specific window during which the cardiovascular system is most vulnerable and, in most patients, least protected by medication. This is not theoretical. The research is consistent across decades and across populations. Cardiovascular events cluster in the morning. The morning surge is the mechanism, and the medication timing is the lever. In 2019, a landmark study was published in the European Heart Journal that sent shockwaves through cardiology. The study was called the Hygia Chronotherapy Trial. Here are the numbers. 19,084 patients with hypertension, followed for an average of 6 years. Half took all their blood pressure medications in the morning as usual. Half took all their blood pressure medications at bedtime. The results were extraordinary. The bedtime group had a 45% lower risk of cardiovascular death compared to the morning group, a 44% lower risk of heart attack, a 42% lower risk of stroke, a 40% lower risk of heart failure. Those are not marginal improvements. Those are not statistical noise. Those are numbers that, if they were attached to a new drug, would be the most significant cardiovascular advance in decades. To put those numbers in perspective, the most celebrated statin medications, the cholesterol drugs prescribed to hundreds of millions of people worldwide, reduce cardiovascular death risk by roughly 25 to 30% in high-risk populations. The Hygia trial showed a 45% reduction from timing alone. No new molecule, no additional side effect profile, no additional cost. And the intervention was free. It was simply moving the medication from morning to bedtime. Here is what makes this finding so significant for the older adults watching this right now. The trial specifically included patients with conditions that are common in adults over 60. Diabetes, kidney disease, existing cardiovascular disease. These are exactly the patients for whom the morning blood pressure surge is most dangerous. And these are exactly the patients who showed the greatest benefit from the timing shift. Here is why it worked. When you take blood pressure medication at bedtime, it reaches its peak concentration in your bloodstream during the early morning hours, precisely when the surge is occurring, precisely when your cardiovascular risk is highest. The medication is working hardest at the moment your system needs it most. When you take the same medication in the morning, it peaks in the afternoon. It wears off overnight. And your most vulnerable hours, the early morning surge, are covered by the lowest levels of medication in your system. The wrong timing means the medication is fighting the wrong battle at the wrong time. If your doctor has never once discussed medication timing with you, drop a comment below right now. I want to know how many people this applies to. This is where I need you to pay very careful attention, because this is not a blanket recommendation to take everything at night. The timing change applies to specific classes of medication and the exceptions matter. Here are the medications for which bedtime dosing has the strongest evidence. ACE inhibitors, lisinopril, enalapril, ramipril. These are among the most commonly prescribed blood pressure medications in older adults. They work by blocking the renin-angiotensin-aldosterone system, a hormone cascade that constricts blood vessels and raises blood pressure. When taken at bedtime, they reach peak concentration in the early morning hours, providing maximum coverage precisely during the surge window. When taken in the morning, the peak effect occurs around midday, when blood pressure is already naturally declining, and the medication's effect is largely spent by the time the surge begins the following morning. A critical additional benefit, ACE inhibitors taken at bedtime have been shown to better suppress the overnight rise in the hormone aldosterone, which is one of the drivers of the morning surge itself. You are not just treating the surge, you are suppressing part of the mechanism that causes it. ARBs, angiotensin receptor blockers, losartan, valsartan, olmesartan, irbesartan. These work on the same hormonal pathway as ACE inhibitors, but at a different step. The same morning timing advantage applies with equivalent evidence. Many patients transition to ARBs when they experience the dry cough that ACE inhibitors can cause, and the bedtime timing evidence applies equally to both classes. Calcium channel blockers, amlodipine, diltiazem, verapamil, these work differently. They directly relax the smooth muscle and arterial walls, reducing resistance. Amlodipine in particular, one of the most prescribed medications in the world, taken by tens of millions of adults, has a half-life of 30 to 50 hours, meaning it stays in the system for an extended period regardless of when it is taken. But here is what the data shows even with a long half-life. The concentration curve still matters. Timing amlodipine at bedtime shifts the peak concentration into the early morning hours and measurably improves the morning blood pressure profile compared to morning dosing. These three classes, ACE inhibitors, ARBs, and calcium channel blockers, represent the medications for which the bedtime timing evidence is strongest. And these are among the most widely prescribed medications in adults over 60. There is a high probability that at least one of your current blood pressure medications falls into one of these categories. Now, the exception I promised you at the beginning. This is the one that must absolutely stay in the morning. And this is the one that, if you switch it to bedtime based on a general recommendation without knowing this, will disrupt your sleep and increase your fall risk. Pay attention here. Here is the exception that can cause real problems if you miss it. Diuretics. Hydrochlorothiazide, chlorthalidone, furosemide, the water pills that lower blood pressure by increasing urine output and reducing fluid volume. Do not take diuretics at bedtime. The reason is simple. Diuretics work by making you urinate more frequently. If you take them at bedtime, you will be urinating multiple times throughout the night. Sleep fragmentation, disrupted rest. And for older adults, multiple nighttime trips to the bathroom carry a real and serious fall risk. Falls in adults over 65 are among the leading causes of serious injury and loss of independence. Diuretics belong in the morning, ideally taken at least 6 hours before you plan to sleep. If your blood pressure regimen includes both a diuretic and an ACE inhibitor or ARB, the answer is split dosing. Diuretic in the morning, the other medication at bedtime. This is a well-established approach that your physician can help you implement. Let me tell you about a woman described to me as a retired teacher, 68 years old, from Florida. She had been on lisinopril and hydrochlorothiazide for 7 years, both taken every morning at breakfast. She was diligent. She never missed a dose. Her blood pressure was technically controlled, within range at every office visit. But she had experienced a TIA, a transient ischemic attack, 14 months earlier, at 6:40 in the morning, while she was still in bed, transitioning from sleep to waking. Her neurologist had found no structural cause. Her cardiologist had found no arrhythmia. The event remained unexplained in her file, labeled as cryptogenic, medical language, for we do not know why this happened. For 14 months, nobody had asked what time she took her medication. When we reviewed her timing in the context of that morning event, the picture became clear. Her lisinopril, taken at breakfast around 8 a.m., was reaching peak effect around 2 in the afternoon, when her blood pressure was already naturally lower. By 4 or 5 in the morning, when her blood pressure was surging before she woke, the medication's effect was at its lowest point of the day. 7 years of a completely unprotected morning window. 7 years of the highest risk hours receiving the lowest medication coverage. The TIA had not come from nowhere. It had come from that window. We moved her lisinopril to bedtime and kept her hydrochlorothiazide in the morning. Her 24-hour ambulatory monitoring showed a dramatically improved early morning profile. Her cardiologist described it as the best blood pressure control he had seen in this patient in years. The medication had not changed. The dose had not changed. The diagnosis had not changed. Only the timing, and the word cryptogenic was removed from her file. Here is the practical framework. First and most important, do not change your medication timing without speaking to your physician first. I want to be direct about this. The timing change I have described, moving certain medications to bedtime, is well supported by evidence and is increasingly recommended by cardiologists. But your specific medication regimen, your kidney function, your history, and other factors your physician knows about you are relevant to this decision. What you can do right now is have the conversation. When you call or see your physician, say these exact words. I have been reading about the Hygia Chronotherapy Trial and bedtime dosing for blood pressure medications. Given my current regimen, would it be appropriate to move any of my medications to bedtime to better cover my morning blood pressure surge? And have we ever looked at my overnight blood pressure with ambulatory monitoring? That conversation, those specific sentences, will accomplish 3 things. It will signal that you are an informed patient who has done research. It will introduce the specific study that supports the change. And it will open the door to ambulatory monitoring, which may reveal a nighttime problem that nobody has ever measured. Most physicians will either agree with the change or explain the specific reason it does not apply to your situation. Either outcome is valuable. What you should not do is continue taking every medication at the same time you always have, because that is what the habit established and nobody ever questioned it. The habit was never based on evidence. It was based on convenience. And the evidence now points clearly in a different direction for specific classes of medication. Let me leave you with something that I think about often. Blood pressure medication is the most commonly prescribed class of drugs in adults over 60. Hundreds of millions of people take it. Most of them take it in the morning because that is when they wake up. That is when the bottle is out, and that is what the habit became. Nobody told them about the morning surge. Nobody explained the circadian rhythm of cardiovascular risk. Nobody mentioned the Hygia trial or the evidence for bedtime dosing. Nobody asked what time they take their medication. And in the gap between what the evidence shows and what patients are actually doing, cardiovascular events are occurring in that unprotected early morning window every single day. The medication is right, the dose may be right, the timing may be wrong, and the timing is free to fix. Think about what that means for a moment. Not a new prescription, not a lifestyle overhaul, not an expensive intervention. A change to what time you open the cabinet. supported by a trial of nearly 20,000 people followed for 6 years, with results that showed a 45% reduction in cardiovascular death. You now have the information. You have the specific sentences to use with your physician. You have the names of the medications for which the evidence is strongest, ACE inhibitors, ARBs, calcium channel blockers, and the exception, diuretics, that must stay in the morning. And you have the question about ambulatory monitoring that could reveal a nighttime blood pressure problem nobody has ever measured. One conversation with your physician. One possible change to when you open that cabinet. The research suggests it could be among the most impactful single adjustments you make for your cardiovascular health. And it costs nothing but the conversation. If this video gave you something concrete and actionable, please subscribe. I make videos like this every week because the information that genuinely changes outcomes is not always the information that gets discussed in a 15-minute appointment. And before you go, next week I am covering something that connects directly to everything we discussed today. The specific foods and supplements that are quietly working against your blood pressure medication, compounds that reduce its effectiveness, increase its side effects, or create dangerous interactions that most patients are never warned about. If you are on blood pressure medication, that video is essential viewing. Leave a comment. What time do you take your blood pressure medication? And has your doctor ever discussed timing with you? I want to know how many people watching this were never told any of what I just explained. I am Dr. Harris. Take good care of yourselves. I will see you in the next one.